All right, guys, this is the section on pain, at least the beginning of it. We're going to talk about drugs, of course, but this lecture is really just going to be focused on the different agents used to treat pain. You can have a lot of applications to analgesic management, so I'm not going to go into every single aspect. You could use, some sort of analgesic. And we'll talk about the next set of slides. We'll talk about osteoarthritis and rheumatoid arthritis specifically as sort of separate subtypes of pain management. But this lecture will focus on the actual drugs themselves. All right, first a review of bone mineral density information and a case to go along with that. So here we have TL, 82-year-old man with osteoporosis, started on alendronate 6 months ago. He complains of significant reflux, confesses that he often takes medication with food as he forgets to do so beforehand, also admits to sometimes laying down a bit after his breakfast. Reviewing his clinic note shows he has a history of medication compliance related issues. Which of the following medication may be a better option for TL? TA, not the rapper, the patient in this case. So you've got several choices here. Risendronate and ibandronate probably going to carry the same risks with them. They're both oral medications. So, you really aren't getting any benefit. Remember, there's not a lot of evidence that shows that one of these drugs is more effective than the other. When you're comparing them all head to head, they're all pretty equally efficacious. So that leaves you with choices C and D. D would be the oddball, since it's not in the same class as the other three. Calcitonin is just something we don't use on a regular basis for this type of a patient. So it's more for some resistance to a bisphosphonate drug. It could be used as a treatment for acute hypercalcemia. Excuse me. And that leaves us with C, zoledronic acid. So what I want you to remember about zoledronic acid is that you have a drug that's once a year. It's an infusion. So for a patient like this, you can set him up so that he goes into his infusion center once a year. He's done. He doesn't have to worry about taking it every day. He doesn't have to worry about the restrictions around it. So just an adherence-related question there. All right, this is a Big Lebowski reference if you haven't seen the movie. I'm not trying to condone gun violence, so just ignore this, I guess. All right, the World Health Organization has this analgesic ladder in how they think medications should be used. And this line of thinking is pretty common in the general medical community, at least in the United States. I'm under the impression Europe treats pain, or from what I've heard, Europe treats pain quite differently than we do. They don't use many opioids at all. And so, of course, Americans become the laughing stock of the world, that we're all addicted to Percocet, which hopefully isn't true. But there is some of that we'll get to later about using opioids correctly. However, I do think they have a role in pain management. Certainly, there are pain syndromes that are intense, and we want our patients to be comfortable. And opioids do generally do the best job of that. So when we're talking about pain, mild pain is, however you're going to define that, could depend on what you're talking about. So a mild pain for a cancer patient could be much different than a mild pain for a post-op appendectomy, right? It depends on what you're talking about. But generally speaking, what we do is we use pain scales, so like a 1 through 10, right? And ask a patient. It's probably one of the most common things somebody gets asked in the hospital: how's your pain on a scale of 1 to 10? It's a way we can assess somewhat objectively, but it's also obviously a subjective thing too. And it gives patients some control. They say, well, this is 10 out of 10, worst pain I've ever had in my life. That might give you a starting point as far as what drugs you want to use there. So for somebody with mild pain, and I would say mild pain would be, if you're going to use the pain scale, probably anything less than a 5 or a 6. Once you get higher than that, I think that's pretty intense pain for somebody. Again, it's a bit subjective, and you can of course use clinical judgment, but there is got to be a cutoff somewhere. So like, let's say you're ordering a medication for a patient and you want them to have as needed acetaminophen and ibuprofen, but you also want them to have a narcotic or an opioid on board for more severe pain. So you have to define those cutoffs for your nursing staff, because if you order everything and just say, well, here's 3 medications, give them as needed for pain, your nurses are kind of be like, well, what do you mean by that? What pain do I do? So you actually you're talking about a hospitalized patient, you really have to be very specific on how you're directing your pain orders. That's actually a big Joint Commission requirement. They don't like it when providers leave things extremely open-ended for nurses. They want nurses in the hospital to have a strict set of rules that they're following when they're giving medication. So hierarchy is a really big deal with pain. Just keep that in mind. Now on the outpatient side, it's about patient education. So telling a patient, this is something I want you to start with, and then if that doesn't help your pain, take this. That's a good way to do it. That doesn't require assessing pain scores. I mean, if your patient understands, the pain scale and can be competent enough to use something like that, sure, go ahead. But I think it's a lot easier to say, start with this and then get to this if it doesn't help you. So our non-opioids are going to be acetaminophen and NSAIDs for the most part. Paracetamol is another word for acetaminophen. It's I believe it's a European term that they use in most of Europe, but acetaminophen is what we call it in the United States. Aspirin would fall under this category as well. In the middle category, you basically have a group of weak opioids. So for mild to moderate pain, this would be like codeine and tramadol, plus some other non-opioid types of adjunct therapy. So there's some other things we'll talk about that sort of float in the middle. There's some topical products that can actually be quite effective for patients, and it depends on the type of pain. But we'll get to those middle of the road ones. And then, of course, at the top, you have an opioid. So morphine, fentanyl. This would apply for orals as well, so oxycodone, hydrocodone. All right, let's start at the bottom of the ladder and talk about NSAIDs first. NSAIDs are probably one of the most popular drugs taken on a daily basis by anyone throughout the world. So estimated anywhere from 15 to 20 million Americans using an NSAID on a daily basis, so pretty frequent. These are mostly over the counter. There are prescription NSAIDs, but some of the most effective ones like ibuprofen and naproxen are available over the counter. There's not a lot of evidence that says we really need to go beyond them. Those are well studied to be actually quite effective NSAIDs. So we're talking about OTC ibuprofen. Can you prescribe a different NSAID? Sure, you can. There's prescription stuff out there, and we'll talk about those drugs here and where you might want to use them. But for the most part, you really aren't going to get a lot of benefit beyond those basics that you can buy OTC. As we get a larger portion of our population over the last few years moving into retirement and even elderly status, so we're talking about the baby boomer generation for the most part. And what we're seeing is, and what we've seen already, this isn't anything new, but a lot more demand for analgesic medications. So with our aging population, as you get older, you get more pain. Your joints are worn down. Osteoarthritis becomes much more prevalent. And there's other things that of course, can cause that too. More surgeries, things like that can put people at higher risk for having different types of pain syndromes. And so it's something we need to be mindful of because the older the patient population gets, the more at risk they are for NSAID-related side effects. NSAIDs are relatively safe for young people, but there are some risks associated with them. As far as historical use, salicylates like aspirin were used pretty much exclusively until 1950, and then they tried to make some non-salicylate attempts in the 50s that were toxic, and then indomethacin, which is still an NSAID that's used today. They use it in OB medicine a lot. Is the first relatively safe NSAID that came to the market. So today we have 20 different NSAIDs available to us at our disposal in our arsenal, and there's 6 different pharmacologic categories. I honestly don't care about them. You'll see, if you read more into NSAIDs, you'll see they're broken up into all these different categories. It doesn't matter. An NSAID's basically an NSAID. We don't mix and match them regardless of what category they fall into. It's a class, so you use one drug from the class. You don't double up on it. It's pretty straightforward. So I don't think there's any reason to go into the different categories unless you want a lesson in pharmacology, which none of us really do, right? Even though it's the name of the class. We aren't going to go down that road. The differences between the NSAIDs mostly have to do with kinetic profile, so how long it lasts, how frequently they have to take it. There might be some potency things there. There's some perceived potency differences, but I think the major studies out there say that NSAIDs really don't have a huge difference in response. If you give somebody oral ibuprofen or IM ketorolac, I combined the brand name and the generic there. But if you give somebody IM ketorolac, which is thought to be a more potent NSAID, are you getting more benefit? And actually, there's some acute pain studies, especially in emergency medicine patients, that say no, actually, an oral medication like ibuprofen is as effective as an IM shot or an IV shot of ketorolac. So we'll get to some of those drugs here in a second. But basically, when we're breaking all this down, there's not a lot of huge advantages for going outside the norm when it comes to NSAIDs. You do have some convenience aspects here, so there are some short-acting NSAIDs, like ibuprofen would be a short-acting NSAID. You take it 3 to 4 times daily to get continuous results, whereas something like naproxen would be about a twice-a-day medication, so you get some advantages there with patients. Patients might respond well to one and not another, so certainly there could be rationale to change, but I'd always start with your basics, which again are going to be ibuprofen and naproxen. They're well known, well studied, and you can buy them over the counter. They're pretty inexpensive. We talked about arachidonic acid briefly last fall, and today we'll go through in a little bit more detail. So arachidonic acid is an eicosanoid precursor. Eicosanoids are inflammatory and immune messengers, and they're released, or arachidonic acid is released by a variety of stimuli. So most commonly what you experience is tissue injury is going to cause some sort of a release of arachidonic acid, and then you get upregulation of production and release of eicosanoids, which gives you inflammation, which can be a source of pain in some patients. We talked about the cyclooxygenase enzyme and how it turns arachidonic acid into different downstream molecules. So you have prostaglandins, prostacyclin, thromboxanes, and leukotrienes. We talked about leukotrienes with respect to asthma. We've talked about and asthma and COPD. We talked about thromboxanes with respect to platelets, and prostacyclin more so with respect to pulmonary hypertension. So in this case, what we're looking at is our prostaglandins, and that's really where the source of inflammatory related pain is going to be coming from. So here's just a diagram that shows what you're looking at here. You have two different major types of COX enzymes, 1 and 2, and they do a little bit different things. So let's move on to that. COX-1 is a constantly active enzyme, and it's sort of a housekeeping enzyme. It's good for us to have COX-1 available. It promotes production of housekeeping prostaglandins. So for example, these prostaglandins protect our gastric epithelial cells. And so if you decrease the ability of your body to have these housekeeping enzymes available, you can end up with a situation that puts your GI at risk for a possible bleed. And we'll get to that more later, but that's just an example of how NSAIDs maybe have some collateral damage. It's not really related to their analgesic effect. COX-2 is the inducible enzyme, and it's likely going to be upregulated during stimuli or during various stimuli, and major source of inflammation and cancer-related prostaglandins. So when we're talking about NSAIDs, your NSAIDs are either one of two things. They're non-selective or they're COX-2 selective. We don't have any NSAIDs that only work on COX-1. That would be pointless. It would cause a lot of side effects and no analgesic relief. So what you might see is a pure COX-2 agent. We have one of those on the market and some other NSAIDs that are heavily COX-2 with minimal COX-1 inhibition. But most NSAIDs are going to be both. They're going to be somewhat non-selective for both. And we've actually seen that non-selective NSAIDs actually don't have that much higher of a GI bleeding risk than some of our selective ones. So it's sort of interesting when you look at some of the data that does this really matter all that much? And it's a good question. I don't think we fully understand it yet. This chart generally shows what we're looking at here. So non-COX, so this would be a non-selective NSAID. You got ibuprofen and naproxen, indomethacin, ketorolac, probably the ketorolac, naproxen, ibuprofen, 3 most commonly used NSAIDs right there, all non-selective. NSAIDs with some COX-2 activity. I use this because it breaks them down easier, but basically this would say that these drugs lean a little bit more COX-2 than COX-1. You can see some of them there. Most of these drugs don't use a whole lot. Diclofenac does get some use, but it's mostly in topical preparations, which we'll talk about in a bit. And COX-2 selective NSAIDs. So these drugs, all these that end in coxib, are either not on the market or not available anymore. The only drug that we have that's COX-2 purely selective is celecoxib. Now, meloxicam and etodolac are put over here too. Technically, they are heavily COX-2 favored, but they still do have some non-selective properties, so they will inhibit COX-1 to a degree. Your only pure COX-2 is celecoxib. All right, safety concerns. We talked about this with acute kidney injury. These are major causes of acute kidney failure for our patients who take these and they're dehydrated, or take them with an ACE inhibitor and they're dehydrated. So we talked about all that, so I'm not going to rehash that totally. What these are showing here is a couple of different graphs that are looking mostly at GI bleeding. So since we haven't talked about GI bleeding, let's mention that right now. I already mentioned it briefly. But this is basically the relative risk you have of getting a GI bleed on a NSAID. So you can see that this chart shows that ibuprofen is actually one of the lowest risk, even though it's a non-selective NSAID. This chart also doesn't have celecoxib on it. This one does, and so it's another meta-analysis that looked at a bunch of different studies. And celecoxib does probably have the lowest GI bleeding risk, and then rofecoxib isn't available. Then ibuprofen here, again, quite low risk, not as low as celecoxib, but really nice side effect profile overall for an NSAID and for a non-selective NSAID on top of that. And the pregnancy risk factor there, I'll get into this in a little bit more detail, but NSAIDs and pregnancy, there's a bit controversial. It's a bit controversial there. Generally speaking, NSAIDs shouldn't be used in pregnancy. However, there are some times when it's relatively safe to do it. Usually we aren't doing it right before labor. We can actually use NSAIDs as a tool for us when it comes to labor and delivery, which is sort of a different indication. It's non-analgesic. And in those specific patients, it can actually prevent preterm labor from occurring or continuing. And it does so by decreasing, obviously, prostaglandin productions, but that has some effects on the smooth muscle of the uterus. We'll talk about that a little bit more specifically during OB. But this is just an example of that we do use it in pregnancy-related indications. However, there is a hard and fast rule that generally we're sticking to certain trimesters when it comes to NSAID use in pregnancy, with some evidence saying that they would be safe-ish to use in second trimester. Generally speaking, first and third is sort of off limits, but second is maybe okay. This is of course, at the discretion of the provider, and some people may have differing opinions on this. So if you want to be sure about it, I would just say try and avoid them if at all possible, but sometimes that's not always the case depending on the condition you're trying to treat. So the concept of GI bleeding, we have a decrease in housekeeping prostaglandins. If that prevents this mucosal gel layer from forming appropriately, you can end up with hydrogen ion exposure directly to the cells, which can cause damage, and that's how you can end up with GI bleeding. Normally, this only happens if people take NSAIDs fairly high doses and fairly regularly, like one-time PRN, probably not going to have a huge impact on the way that this process affects it, but still theoretically possible. Patients who are at risk are age 65 or older for the most part. Creatinine clearance low. If they have a low creatinine, they're not going to eliminate the NSAID as much, and that could keep it around a little bit longer theoretically. Prior ulcers or GI bleeds, of course. Any type of anticoagulation or antiplatelet agent. Some other things too, which we'll talk about later, like SSRIs and their risk, mostly pretty low. Consider chronic, again, versus PRN. So people who take NSAIDs regularly are going to be at much higher risk. Prevention overall, try and limit use to as needed. COX-2 selective inhibitors can be a little bit better on the GI tract. And you can also give your NSAID with a antacid regimen, like a proton pump inhibitor or a histamine 2 antagonist. Some other things to think about with NSAIDs too. If you ever have patients on lithium, which is a mental health medication used for bipolar disorder, NSAIDs can interfere with the renal clearance of it and increase lithium levels systemically. We try and avoid NSAIDs with lithium use because lithium is a pretty narrow therapeutic index drug and can get toxic quickly, so we want to try and avoid that with our patients. Antihypertensives, if you're trying to control somebody's blood pressure and they're taking NSAIDs regularly, it can work against the body's natural ability to vasodilate, and that can have, of course, an impact on how the body's going to respond to different blood pressure treatments, and can just generally raise baseline blood pressure. So I always recommend asking people, if you're assessing hypertension, do you take NSAIDs, and if so, how regularly? If they're taking them regularly, that's going to be it's going to be counterproductive to managing hypertension. And again, just don't double up on NSAIDs. This is easier said than done. Patients may not realize they're in the same class and they're over the counter, so they might buy Aleve and Advil and take them both because they don't necessarily realize that they're technically pretty much the same drug, and that can put you at higher risk for GI bleeding and other issues like kidney failure. There's a lot of controversy around COX-2 selective NSAIDs and CV risk, which is why only one of the products is on the market right now. So Vioxx was this drug that was originally the competitor to Celebrex, and was pulled from the market because they found a twofold risk of increased cardiovascular events compared to the placebo patient population, and they actually pulled it. Celebrex didn't show this risk, but at higher doses did. So Celebrex has a lot of restrictions on how frequently you're supposed to dose it. And even though celecoxib is thought to be safer, it's still recommended you avoid it in patients with high cardiovascular risk. So the question is, all NSAIDs inhibit COX-2 to some degree, so do all NSAIDs have this risk? And yeah, theoretically they do. Based on a lot of meta-analysis and retrospective looking at some of the responses patients have had from NSAID use, naproxen is thought to have the lowest overall CV risk, but does have a sustained antiplatelet effect at higher doses. So it's thought to maybe decrease the clotting potential, so maybe improving things. But basically what we're looking at is generally increased thromboembolic related complications, so myocardial infarction and things like of that nature that people are experiencing on these drugs. So what's the risk? Small, usually 1 to 2 per 1,000 person years. And if somebody has low CV risk or none, there's virtually no risk in taking NSAIDs. And also, if you take into consider short-term acute therapy, there's also very little risk. So every once in a while you see articles like this pop up that are sort of like, don't take NSAIDs, they're bad for your heart. Well, they might be, but only probably if you have some pre-existing conditions or you're taking them really regularly for a long period of time. Generally speaking, heart failure patients and people with uncontrollable hypertension should avoid NSAIDs altogether, though. Another controversy that's come up with NSAIDs is their interference with aspirin, and it's thought that NSAIDs interfere with antiplatelet activity via competition with aspirin for binding site on COX-1, and this prevents the irreversible reaction that inhibits COX-1 for the remaining life of the platelet. This isn't seen with celecoxib or diclofenac, interestingly enough, but celecoxib might be better for not having this aspirin interference. Ibuprofen and naproxen are both shown to interfere and get around by spacing the drugs about 2 hours apart. So take the aspirin in the morning, and then take your NSAID a couple hours later. That can help a little bit because you aren't having the drugs in the systemic circulation reaching their max concentrations at the same time. Naproxen is likely lower risk, but also has a longer half-life to consider. NSAIDs of all kinds are generally contraindicated for perioperative pain, for CABG surgery, and usually people aren't going to be using NSAIDs at all before surgery due to their perceived interference with platelet aggregation. Here's my joke. Don't overdo it on NSAIDs. Okay, the ceiling effect is sort of an interesting discussion point. The idea is that you can only get so much analgesia out of an NSAID, and pushing the dose higher will result in more side effects and less advantages in analgesic relief. So there's thought to be a couple ceilings, maybe an acute versus chronic, with chronic being a little bit higher. So if you're taking it regularly for osteoarthritis, you might have a bit higher of a dose ceiling than you would if you're just taking it acutely. It's also thought that if you take the drug at higher doses, you also get anti-inflammatory and not just analgesic responses. So it kind of depends on what you're trying to target here. One example is it's thought that ibuprofen really has a max dose of 400 milligrams for pain, but 800 milligrams for inflammation. So this is where things get confusing on what is exactly causing the pain, because it's an inflammation that we're trying to target, yes, but some of the studies for acute mild pain looking at NSAID use have shown that you just don't get any more analgesic relief off of a higher dose NSAID. So in the literature, you might see different goals for different types of indications, which is pretty common with NSAIDs. Now, how important is this? I think it's really practice specific. For example, if you practice in urgent care or emergency medicine, you should have a good handle that the literature doesn't really support giving high doses of NSAIDs. It is not shown to be beneficial to patients. If you work in different post-op pain or in a rheumatology clinic, you might be dealing with a whole different set of data from those patients. Okay, starting with aspirin. So salicylates are technically an NSAID. They do have anti-inflammatory properties via COX inhibition. So you could use them for pain. However, the problem with salicylate, specifically aspirin, is that you get the doses you need to give somebody for analgesic effect are really high, and aspirin just has a lot of GI tolerability things. People tend to get pretty significant dyspepsia with high doses, so it usually has a rate limiting effect, and people aren't going to tolerate it all that well. So for that reason, you aren't going to see aspirin used for this role a lot as a pain medication. Sometimes I'll see people take like 325 of aspirin, or the full strength antiplatelet aspirin, twice a day for pain, and it just doesn't really seem like that's going to do anything. Maybe it does work for some people, but for the most part, you'd need a pretty high dose. That's not going to be tolerable for the average patient. Salicylate is another medication that is a salicylate, but it's kind of rarely used. This one is something that can be a nice alternative for people who, for example, can't do NSAIDs because of previous GI bleeds or possibly kidney issues. Salicylate might be an alternative. It's not quite as risky side effect, but also it's not going to be as effective as a standard NSAID. So you got that trade-off there. Acetaminophen, I put it in here because there's no real other category for it. Acetaminophen is not technically an NSAID, but it's close enough to in the realm of what we're talking about that I think it fits well here. So acetaminophen has a couple things about it that I think work really well, but overall it's a pretty weak analgesic medication. The nice thing about acetaminophen is it's very, very well tolerated. There's virtually no side effects to taking Tylenol unless you take a ton of it. So acetaminophen is available oral rectally, and there is also an IV product. Why you'd want IV Tylenol? It's a great question. We have that at our hospital, and it's sort of like a constant battle with our providers over using it because it's really expensive. And there's not a lot of data that compares it directly to oral Tylenol. So there's some interesting studies out there that say, hey, if you give your patient IV Tylenol in a post-op setting, they'll use less narcotics. Well, that's great, but they don't have studies comparing that to what if you use oral Tylenol. Oral Tylenol costs like a penny for a tablet, and the vial costs like $100. So there's a big difference there, obviously, and it's something we want to work out more. But it is available. So for patients who are PO intolerant and you want maybe an anti-inflammatory medication or something else on, it is an option that is available. 4 grams a day is something I want you to know. So it's not really it's not with respect to dosing Tylenol too much, but it's the max daily dose. So you can dose Tylenol under the 4 gram mark per day, but I do want you to know for the exam that 4 grams is the max dose. The reason is that, we'll talk about Tylenol side effects here in a second, but if you get over the dose limit, you can put yourself at risk for some significant problems. Tylenol is a pretty good antipyretic, and it's an okay pain reliever. The nice thing about Tylenol is it should work, and NSAIDs actually for this matter kind of all fall in the same category. It should work pretty quickly. So you give somebody a dose of Tylenol in 30 minutes, you should know if you've had an effect on them or not. Maybe an hour at most, but then you can move on to the next thing. Not like you have to wait a week of using Tylenol to see if it's going to have an effect for somebody. It should work pretty quickly. And again, if it doesn't work, move on to something else. You can combine acetaminophen with pretty much every other pain, actually I think every other pain medication out there that I can think of. There's some, I hear this every once in a while where people say, well, you can't take Tylenol and ibuprofen together. Yes, you can. You can take them at the same time. They're different medications. Acetaminophen is not an NSAID. It doesn't have any GI bleeding risk. It's not renal. It doesn't have any renal issues associated with it. So certainly you can take that with ibuprofen. I think sometimes where providers get a little concerned is that their patient won't remember which one they took. So if they're taking both at the same time, like maybe they say, well, okay, in the provider's mindset, they might see their patient messing it up. So they say, well, the patient took a dose of ibuprofen in the morning and they want to take Tylenol, and then they think, well, okay, did I take Tylenol or ibuprofen already? And I think it's just a matter of if you're going to have somebody using 2 pain medications, and this would go for any 2 pain medications really, it doesn't have to be Tylenol, but it would apply here, of course, as well, is just have them keep a little log, keep it on their phone or keep a handwritten log, when they're taking it. Especially true for kids. I've had kids with mild fevers where I've alternated Tylenol and ibuprofen. It's a really effective strategy, especially when that ibuprofen doesn't quite make it to the next dose. You can pop in a acetaminophen dose on top of it, and I've done that a lot, and it works. I think it works pretty well. You just have to remember, and I feel like I'm qualified to do this, but sometimes you'll have providers say, don't do that in kids because you'll end up overdosing your kid accidentally because you'll give the wrong thing. There's nothing pharmacologically or antagonistic about the medications. They again, they work differently. You can certainly give them together, but just know that there's that somewhat controversy there. And acetaminophen is generally thought of as quite safe in pregnancy. Every once in a while, you read a meta-analysis. Like I think I read one a while ago about what was it? It was acetaminophen and ADHD. That people who took acetaminophen while they're pregnant had higher rates of ADHD in their kids. You can find these correlations places, but at the end of the day, there really isn't any solid evidence that there is any risk with acetaminophen. It's thought to be a very well received medication. It's one of the only ones that pregnant women can take, so it's certainly worth a try if they have headaches or other pain syndromes. Some of the problems with acetaminophen, it comes combination with a lot of other things. So over-the-counter cough and cold medicines. This is where people get in overdose possible situations. So let's say you have a cold and you're taking extra strength Tylenol for the pain or a fever or something. And on top of that, you're taking, I don't know, some sort of a Dayquil, which also has Tylenol in it. People might not realize that it's got the same ingredients, and that's where you could end up possibly going over your daily limit. So it's always important to consider that. A lot of painkillers have Tylenol in them too. So if you're giving somebody something for acute pain or post-op pain, Tylenol or acetaminophen combined painkillers are really popular. So drugs like Percocet and Norco, probably some of the most commonly prescribed drugs in the country, I would say. And you have the problem of people overdoing the Tylenol because they might go home, and if they aren't educated, they might take an extra dose of Tylenol on top of their combo analgesic medication. So it's really important just to reiterate, this has Tylenol in it, this has acetaminophen. Don't take any other acetaminophen products. Talk to your pharmacist before you start something new. Simple stuff like that, I think, can go a long way to preventing an accidental overdose situation. Tylenol doesn't really have any drug interactions to speak of. It's hepatically metabolized, and if you take a ton of it, you can interfere with some other hepatic pathways, but ultimately at its standard dose, you're probably not going to see it. I have some pharmacists I work with who think that if you're taking the max daily, so if you're up to 4 grams a day, you might see some effects of things like warfarin metabolism, but that's anecdotal. It's not really evidence-based. So theoretically, it shouldn't really have a whole lot of drug interactions to be concerned about. Hepatotoxicity is the big side effect here, and it's more of an overdose effect, a toxic effect, and I wouldn't really even say it's a side effect because it shouldn't happen at normal dosing. Hepatotoxicity, we're going to talk about this in a lot more detail during our tox module this summer, so I'm not going to go into it too much today, other than just to say that it is hepatotoxic at high doses. So if you go over 4 grams a day, you are at risk. Usually you're looking at 7 grams a day, 7 grams in one day to be at that risk, so like double the daily amount. So you do have to really push it. If you take one extra dose, if you're at like 4,500 for the day, I would say maybe just cool it the next day, probably at very minimal risk of Tylenol. And basically the mechanism behind it is your body creates an intermediate and can only, when your body metabolizes Tylenol, it can only metabolize so much. And if it uses up the enzymes that are responsible for metabolizing Tylenol, what you end up with is a shunted pathway that the liver doesn't normally use that causes a hepatotoxic intermediate to be formed, and the body can't clear enough of that. And if you do that enough, you can end up with a hepatotoxic situation. So there's usually 2 ways people do this. They overdose on a lot in one day. That's usually more intentional. It's kind of hard to do that accidentally, I think, to take like double the amount, but certainly possible, especially if you're combining combination products. The other thing that is concerning is chronic. So chronic ingestion, if you're chronically doing 5 to 6 grams a day of Tylenol, that certainly can put you at risk as well. This is one of the most common overdosed medications in the country. Fortunately, it is actually, even if you do a pretty substantial overdose, we have a really good antidote for this, which again I'll go into during tox, but it is something that we can treat very well. And so most people don't go into liver failure because of this, but there are a small amount of patients that will lose their livers because of Tylenol ingestion. All right, ibuprofen, most commonly used NSAID for sure. It's similar to acetaminophen when it comes to OTC use, and by that I mean there's a lot of combo products out there that are Advil or Motrin branded, Motrin cold and flu, Advil cold and flu, and sometimes they don't even have ibuprofen in them. They're just branded that way. That's why over-the-counter stuff, it's like I don't even bother looking at the name on the front of the box. Like, tell me what the ingredients are, because it's really confusing. So anyway, I don't want you to remember any doses for ibuprofen. But usually you're looking at a single dose being 200 to 800 milligrams each time, and you can do that up to Q6 hours. So the max is going to be 3.2 grams per day. You won't see a lot of people taking that. That's the 3.2 grams per day would be more of an arthritis level dosing. It's pretty high. Of course, if you do that, you're going to put yourself at higher risk for GI bleeds and stuff like that. So you just have to be careful. The over-the-counter tablets are 200 milligrams. I'm sure all of us know this. We've probably all taken ibuprofen recently. And the prescription tablets come as 400, 600, 800. So you can prescribe RX ibuprofen, or you could just tell your patient to take, however many tablets. It's really no different. There's no difference with ibuprofen prescription. They're just gigantic pills. So you can give somebody a massive 800 milligram. Personally, I prefer to just take 4 of the small ones that come OTC. It's really not that big of a deal. Lowest GI bleeding risk, we talked about that. Not really any other side effects or drug interaction issues that we haven't talked about already. And clinically, and studies show that ibuprofen is one of the most effective of all the NSAIDs, really, for pain relief. It really has some good track record and good data behind it. And most studies will show that it is a more effective analgesic than acetaminophen. That's not all that surprising to us, though. Naproxen, again, another great NSAID to try. This one's twice daily dosed, which makes it a little bit advantageous for those osteoarthritis patients that are taking NSAIDs regularly, or anyone who just wants a more sustained effect. They are a kind of similar dosing strategy. The over-the-counter stuff is a little bit lower than the prescription, and there's some different salt combinations. So there's you'll see naproxen dosed 220 milligrams, and sometimes you'll see naproxen sodium dose 250. It's a base versus a salt form. They're really about the same thing, so don't get too hung up if your hospital's formulary is telling you to do 250 and not 220. It's pretty much an equivalent. And you can take about, I think naproxen, a lot of people cap it at 2 tablets a dose, but you can take up to 1,000 milligrams for one dose. That'd be a hefty dose, but it's kind of the equivalent of 800 of ibuprofen. It's a big dose, but you're going to get maybe more of the anti-inflammatory benefit that way. Some of these I left as the acetic acid group, and again, I don't really care that these are acetic acids, but I threw a whole bunch of NSAIDs on this one page. The one I'll talk about diclofenac in a second here, but the one I really care the most about is ketorolac. Ketorolac's thought to be the most potent NSAID, and the reason is a PO drug, it's probably the same as ibuprofen, so it's really not any different that way, but you can give it IV or IM, and there are some studies out there that show that giving something IV or IM does give a better analgesic response in some situations than not doing it. Now, there's some more controversy too, because you're like, didn't you just say that that's not the case? Well, yeah, there are some studies that say that if you do a placebo-controlled, or if you do a control with an oral, like an ibuprofen dose, you get the same effect. So people don't really respond better. The one thing that some people will say is that, if I've got somebody who wants something stronger, and I'm using air quotes here, for pain, is your priority, you can say, okay, I'll give you some Toradol, and then the person gets an injection. They might sort of get a placebo effect after that injection, that they're getting something more powerful than the average oral dose. If you just gave them, well, you can take some ibuprofen, they might feel, I don't know, that's not going to help me, but this Toradol was great. There's been a lot of debate over this in our emergency department group recently. I shouldn't say debate. We have a pharmacist who's very gung-ho about this, and there's a lot of good literature that supports that we're overdosing people on ketorolac regularly. So, for example, For an IV product, a lot of times we're giving 15 or 30 milligrams, and the dose, the literature says pretty consistently that you don't really need to give more than 10 milligrams of ketorolac to get the same effect. Giving 30 is just not going to give you any more benefit to your patient and likely going to put them at higher risk for side effects. The same thing with IM. So when it comes down to it, you have a drug that has some utility because it's the only NSAID we have that's available as a parenteral form. But there is some controversy about how we're dosing it and how we're using it. I don't think it's it's caught on a lot yet, but it is decently studied in the literature that we're not using this dose appropriately. The reason why we're concerned about ketorolac is out of all the NSAIDs, it probably has the highest risk of GI bleeding. So we don't use ketorolac chronically. It's got a 5-day limit on it, and then switch to something else. Diclofenac is mostly used as a topical product, and I bring this up and I gave it its own slide because I think it's a good one to remember that this is an option for patients who might not tolerate NSAIDs all that well otherwise. So especially for people with joint pain or localized pain, like a localized osteoarthritis, maybe in an elbow or a knee, you can apply this locally and it will absorb, and you do get some systemic exposure, but it works better locally. So here's, for example, if you took oral diclofenac, you get 100% absorption. There's a gel, a couple different strengths on the market. It's called Voltaren. I think it comes as a generic now. There's also a patch called Flector. So either one of those would be fine. And again, I think it's a product that's got some good utility, and I'd recommend keeping it in the back of your mind that you could prescribe this to somebody who's maybe not doing well on oral NSAIDs, maybe shouldn't be taking oral NSAIDs. Your systemic exposure is quite low, so your ideal risk of GI bleeding and kidney issues, are pretty low compared to if you're giving somebody an oral dose. Now, it's not totally eliminated, but it is quite a bit better. So if you're looking for the lesser of two evils, certainly if the topical product makes sense, go for it. And it requires somebody preparing something topically and putting it on, but still, it's not at the end of the world, I think, for most patients. Other drugs, there's a few on here that I honestly am not that too much about them. Meloxicam is interesting. It's a once daily NSAID. I think it's the only NSAID that's once daily, so it's got the longest half-life. So for a RA patient, or any type of arthritis patient that's chronically doing NSAIDs, this is a good option in a lot of cases. So you might see this used for that. Otherwise, it's really no better than any other type of NSAID. It is more heavily COX-2 favored, so it's a little bit it's on that selective spectrum, further towards COX-2. And then celecoxib, or Celebrex, is the only pure COX-2 on the market right now. The GI or bleeding risk is minimal. However, when you're taking NSAIDs chronically, you're still probably going to want to use a PPI on top of it, or a proton pump inhibitor. The evidence just shows that you're much less likely to get a GI bleed if you're suppressing the stomach acid production, and proton pump inhibitors work really well for that. The drug is dosed twice daily. It doesn't have any effects on platelet function, but doses greater than 100 milligrams per day, or 200 per day, were associated with cardiovascular failure. So that's what we were talking about earlier on that slide. This is the drug that's a little bit controversial because all of its siblings got kicked off the market because they caused CV events, and this one seemed to, for some reason, it was able to hang on, but there's a lot of things to think about when prescribing this. So again, high cardiovascular risk, previous MI, previous stroke, those types of things, I would say probably avoid this at all, altogether. Try a different NSAID, or maybe avoid NSAIDs at all costs, I think, would be the better thing, not necessarily trying a different one, because that's going to give you the same problem. Okay, that's it for NSAIDs. Let's talk about muscle relaxants quickly. Muscle relaxants are kind of confusing pharmacologically. They don't have a specific mechanism that they all fall into. They're all a little bit different. For the most part, what you're doing is something that's going to, as the name says, going to relax muscles and reduce muscle spasm. They're used short term. You have some long-term possibility too. These would be for patients with like spinal cord injury. So I think it's important to differentiate what's our short-term post-surgery or post-injury muscle relaxant versus what do we use long-term. Some providers will like to use these because they can maybe give this plus an NSAID to somebody, and then avoid using an opioid or other narcotics that way. So some people will do it that way. They are pretty sedating generally, so there is that to consider, and they're mostly anticholinergics. So again, some side effects to think about here. Cyclobenzaprine or Flexeril is one of the most common ones that people prescribe in the acute setting. Mechanism, we don't really know what it does. It probably influences something in the central nervous system on alpha and gamma motor neurons, and maybe some effects on norepinephrine. I know that sounds terribly vague, but that's about the best I can do for you. I don't really know how cyclobenzaprine works. Commonly used and generic. It's not recommended for use for more than 2 to 3 weeks. Just no real reason to do that in most cases. The structure is similar to tricyclic antidepressants, which we're going to talk about during psych. But if you overdose on a tricyclic antidepressant, it's really bad. So if you do a urine drug screening on somebody and they test positive for tricyclics, you're like, well, why are they taking tricyclics? Well, this drug can actually cross-react there. Not super important, but just a little tidbit there. And also anticholinergic. So in an overdose setting, you could get some cardiac issues if you take too much of this, just like any anticholinergic medication. Central nervous system depressions all have vague mechanisms of action. Again, they're likely working on some sort of receptors in the brain, causing a downstream effect where the body is communicating with the neurons either to a lesser degree or to a degree that tells them to relax instead of contract. So again, there's motor neurons, gamma and alpha, and they're probably having some activity on there. So a lot of times we see these central acting alpha receptor modulators that are working in certain parts of the brain. That's a pretty common mechanism here. These drugs are all similar to cyclobenzaprine. So methylcarbamol, carisoprodol, and metaxalone. They're all anticholinergic. Methylcarbamol does come as an IV product, and you might see it used post-op, especially if you work in ortho or spine. Sometimes, well, not ortho, it'd be spine, sorry, for spine surgery. Sorry, our ortho and spine units are combined, so I just, by nature, I say them together. But for spine surgery, a lot, they'll see this used sometimes intraprocedurally, pre-procedurally, and there's some interesting evidence that shows that it cuts down on narcotic use post-surgery. Carisoprodol and metaxalone, you could use them. They're available. Soma has some benzodiazepine-like metabolites that occur, so it is a controlled substance. Benzodiazepines we haven't quite talked about yet, but we're going to get to those during psych and where they come into play. But they do have some muscle relaxant properties with that class of drug as well. So those are our acute drugs. So there's basically 4 you can pick from. They're all probably pretty similar. I think most people go with Flexeril because it's well known to them. It's pretty well tolerated by most patients. I've had plenty of providers tell me that they think it's about as good as placebo as well, but it certainly might be worth a try depending on what your patient's experiencing. Some other agents for chronic use only. So these are going to be people with chronic spasticity issues, so quite a bit different of an indication. Tizanidine is a centrally acting alpha-2 agonist. It's short-acting, 3 times a day dosing, but it's useful for this. It does cause quite a bit of hypotension and sedation. Baclofen is another drug that is really popular for spasticity, and it primarily affects GABA, which inhibits nerve reflexes at the spinal cord level. GABA is gamma-aminobutyric acid, which is a neurotransmitter that has a ton of different effects. And we'll talk about that in a couple different points here throughout the spring, especially when we get into neuro and psych more so. You can take it orally. It also comes as an intrathecal pump, which I've got a picture of on the next slide. Generally not used as an as-needed medication. However, I have used baclofen for ED patients who have irretractable hiccups. It does work for that. So you could use it maybe on demand for certain things, but for the most part, this is something for chronic spasticity more so. And you will get some hypotension and maybe some CNS depression with this medication. And then the benzodiazepines. Benzodiazepines like diazepam, for example, are really lipophilic. And while they are, diazepam's Valium, the brand name. So a lot of people think of it as, well, it's a sedative, it puts people to sleep, but it also has some good muscle relaxant properties, and it does work on the GABA system as well. And by that, it actually potentiates GABA's effects. And by doing that, GABA is kind of an inhibitory neurotransmitter. And by potentiating GABA, you cause sort of a chain reaction of inhibitory response in the brain, which is going to help relax muscles. So Valium's a really popular muscle relaxant, even though it's not technically, like, that's not technically the class, it's used for that quite a bit. And we'll cover that a lot more later in the semester. Here's a baclofen pump. So we have a big rehab unit, so that's why I'm bringing this up. But this is a kit, so you can see it's quite big. But this is where you'd place it, and then it's got a cord that goes intrathecal into the spine and can do a continuous infusion. So it'll help those people who have had chronic spasticity issues, and the pump is refillable via like a port access. So certainly an interesting way to deliver medication, but can be very helpful for some patients. Okay, now we have opioids, everybody's favorite drugs, right? So you guys have probably been waiting with bated breath for this one for quite some time. Opioids, I've got a lot of slides here about opioids. They're a big topic to cover, a lot of controversy, and I want to focus for now on the agents and the analgesic components. Excuse me. We'll talk about drugs of abuse later this semester, and I'll talk about heroin and those types of opioids that are more readily abused. And certainly all opioids have a very high potential for abuse. Pretty much every opioid is a class 3 controlled or class 2 controlled substance, meaning it class 1, if you're wondering how they differentiate that out of C1, is something that has no medical benefits. So the drug that's a C1 would be actually marijuana, for example, is still C1 by the federal government. Heroin is a C1. Some other ones are C1s, but anyway, most opioids fall under C2, meaning there's a medical benefit, but they have a very, very high potential for diversion and abuse. But anyway, very highly prevalent in modern medicine. They certainly have a lot of roles that they fill, and we have mild acute pain to severe chronic pain and everything in between. Patients will respond differently. We'll talk about abuse and addiction very briefly here in a couple slides, but you will get at that percentage of population that's going to struggle with abuse. And I think it's important to be able to understand why that happens and be able to work with your patients on making sure that doesn't happen to them or giving them the best resources possible. There are a lot of dosage forms, everything from oral IV to patches and things like that. We'll go through those. The side effect profile of an opioid overdose or even slight opioid overdose is very specific. It's very easy to recognize, I think. These drugs are fatal in overdose. They cause respiratory depression, and if you take too much of them, you'll stop breathing and you'll die if the drug's not reversed. Very easy to reverse a pure opioid, though. We have a drug called naloxone that works quite well for that. These drugs are generally pretty safe in pregnancy, assuming you aren't overdoing it. It is a safe medication to give a pregnant person. All right, so opioids don't have a ceiling dose. Most patients will, if they're taking it chronically, will build up a tolerance to the medication over time, but there is no top dose. So you might say a person who's opioid naive might take 10 milligrams of a drug and get a great response, whereas somebody who's a chronic cancer patient might be on 200 milligrams of the same drug in a day. It's very variable, and your body will build up a tolerance to the opioid, but there isn't really a max dose of opioid. So certainly there's thought to be maybe diminishing returns, and one of the big problems is that you get your diminishing return happens to be a fatal overdose situation. So I'm not trying to joke about that, but if you think about it in the sense that with an opioid you're giving somebody a medication that's analgesic, but over time it's going to end up the higher the dose they get, the more at risk for side effects they are. So if somebody stops breathing, you've overdone it. But sometimes it can be difficult to get that opioid up to the point where it's analgesically beneficial, but the patient's not super sedated or with heavy respiratory depression. Synergistic. Ultimately, NSAIDs and benzodiazepines work quite well with opioids. You can combine them with Tylenol as well. Studies have shown that combining them with an NSAID or a benzodiazepine gets better pain control with less side effects. So basically, you're using less overall of both medications, and you could combine all three. You could do NSAIDs, benzodiazepines, and opioids. They're all the same thing. Not the same thing. They're all different enough where you can combine them. So you do get a synergistic approach, and I would recommend, if you're giving opioids, to not neglect the NSAIDs and acetaminophen of the world. Make sure that you're incorporating those into the pain regimen too. For a lot of patients, that's going to be beneficial for them. Receptors, mostly what we're talking about are mu receptors. So the mu1 receptor, and these are receptors in the brain that are there to interact with various endorphins that the body produces for the most part. So like if you people talk about a runner's high or whatever, which I don't personally agree with because I hate running. But if you are a runner and or working out or whatever you're doing, or doing something that's generating endorphins, so there's natural mediators, endogenous mediators that the body produces that interact with these receptors. Opioids mimic those components. So what we're targeting here are two major receptors, and usually we're non-selective for mu receptors. So mu1 is analgesia, but it also causes euphoria, has some of the CNS disturbance effects, confusion and dizziness. Then mu2 receptors give you all your side effects. So you get your respiratory depression, constipation. Bradycardia is not a huge one you see with opioids, not one I really think about, but the GI effects like constipation and respiratory depression, of course, are big ones. Meiosis is one that you'll see as like kind of a hallmark presentation of pinpoint pupils with patients who have overdosed on opioids. That's a very easy to look at. There's not a lot of other drugs that cause pinpoint pupils in an overdose situation, so it's sort of yep, that's an opioid. That's an opioid overdose. That guy did a bunch of heroin. That's why his pupils are pinpoint. Kappa and delta we aren't going to talk about a lot. Kappa is has a dysphoric effect to it, and it really doesn't have much of a role in what we're going to explore today. There is one drug that I think we'll talk about briefly, but other than that, not a big deal. So these are your classic opioid toxidrome, if you will. Sedation, altered conscious, low respiratory rate. Again, hemodynamics aren't altered to an appreciable effect. In fact, sometimes we like opioids because they don't cause a lot of hypotension or bradycardia. Constipation is a big one, and that's for short term or long term. So it's always really important to recommend bowel meds for people on opioids. That's going to be a key component in making sure that their care is successful with these drugs. If somebody's chronically constipated, it's going to make things bad. And you can get really badly constipated on opioids. So certainly it's something we need to consider. Nausea and vomiting is probably patient specific. Not all patients are going to feel nauseous on an opioid. Some might not. Small pupils, again, hallmark physical exam type thing. Itching. Some of our opioids can cause a histamine release, sort of as a side product of the way that they work. And the drugs that are more likely to cause this are the ones that are closer to our natural products. So we're going to talk about these, but like our fully synthetic opioids, like fentanyl, very low risk of itching. Semi-synthetic opioids like oxycodone and hydromorphone, minimal risk of itching. Some itching, not as much. Morphine, higher risk of itching. So you have kind of a spectrum of activity there. Physical dependence, of course, is something that we can see with this. And of course, not everyone's going to get addicted to opioids. If that was the case, we wouldn't be able to use them. But there is a portion of the patient that will become dependent on them, and that's unfortunate. But we need to be able to try and recognize that and get ahead of that if we can. So plain opium is a drug that was originally isolated from the poppy plant. So poppies are grown and harvested, and I think I had a slide earlier. Is it up here? Yeah. So what the farmers will do, and this is more for heroin production, by the way. This is not really how we do it in real life. But the farmers will cut the poppy buds with a razor blade or something, and then it secretes this latexy material, and then they scrape that off, and that's where they can isolate drugs from. So that's where they can isolate the opium from. That's where they can pull out and modify whatever medication or whatever product they're looking for. Opium itself isn't a very powerful analgesic. It's 12% morphine, and so we don't really use it all that much. However, it is still available, and really because of its mild opioid abilities, but good job at constipating people. For people with chronic or severe diarrhea, you can consume this as a tincture. So it comes as this like brown liquid. That's really the only use of opium. Oh, and then the belladonna and opium suppositories. So belladonna and opium. Belladonna is an anticholinergic medication, kind of like atropine, but they make these suppositories called B&O, or belladonna and opium. And if you give somebody the suppository, it can help with urethral spasms, which can be quite painful, I've heard. So it is really just has two roles there. So there's not much to know about opium. It's very niche, and you aren't going to see it used all that much. Opium structures. So I just put this on here to show you what I was alluding to earlier with the histamine release thing. So morphine's a natural product. I mean, we can make it synthetically in a lab, but it is something that's derived naturally from opium. And then we have our other drugs that we consider kind of semi-synthetic. So codeine, hydrocodone, oxycodone are all semi-synthetic, and hydromorphone. And you can see the further down we go, the more functional groups you add. So like hydromorphone has quite a few functional groups that make it function as a more potent opioid than oxycodone. And then fentanyl has really a totally different structure altogether that still will interact with the same receptors, but it's much more focused. It won't have as many side effects like with the itching, but it's still going to be a very highly potent opioid. Morphine is an old medication. It's still popular. A lot of people consider it the gold standard for pain relief. It was one of the earliest isolated plant alkaloids that we used, and it's still being used regularly to this day. It's cheap. It's effective. It's available PO, as liquid, as tablets, as long-acting. It's also available as IV too. Morphine has a bit slower of an onset than some other opioids, specifically like fentanyl or hydromorphone, but it's quite effective still. It's still going to be a fast onset. And the one issue with morphine to remember is that it has active metabolites that are renally eliminated. So if you have a patient with renal dysfunction, they're going to accumulate more so. So we try to avoid morphine in elderly patients or people with renal dysfunction to avoid giving them more of an extended opioid than we want. So in those cases, drugs like hydromorphone or fentanyl are going to be better because they don't have the same metabolite issues. But morphine, still a really popular medication that's used very frequently. Oxycodone and hydrocodone I put on the same slide because they're really similar. Oxycodone is thought to be slightly more potent, but they're both really interchangeable, I think. Hydrocodone is a couple different brand names. So you've probably heard of Vicodin before, but Vicodin actually was pulled from the market. Vicodin was a 5 milligram hydrocodone, 500 milligram acetaminophen product. And it was replaced by Norco. Norco was a brand name for a long time that kind of lived in Vicodin's shadow because it was a 5 milligram hydrocodone product, so same amount of hydrocodone, but 325 milligrams of acetaminophen. The FDA came out with a rule a few years ago, that you can't have any products that are combination acetaminophen opioid that have more than 325 milligrams of Tylenol in them. So therefore, Norco kind of took the lead. Now, these medications have been generic, so when I'm speaking in brand name, it doesn't really matter. Basically, you're talking about a combination product, and that's really all there is to it. Hydrocodone isn't usually used on its own. It's almost always combined with acetaminophen, with the exception of this Hysingla product, which is a new 24-hour extended release hydrocodone, which has supposedly some sort of a tablet formulation that prevents people from crushing it. But as I always say, well, where there's a will, there's a way. And if somebody wants to abuse this drug, they will certainly figure out a way to do so. Oxycodone is, again, very similar. It's immediate release in the form of Percocet or by itself. So you can get plain immediate release oxycodone without combination with acetaminophen, which is nice if you want to just go that route and let somebody do acetaminophen on their own and then give them some oxycodone to supplement. But a lot of times people will use Percocet, which is 5 milligrams oxycodone, 325 acetaminophen. And these drugs come in varying components too. So you'll have like a Percocet 5 325, Percocet 10 325, Percocet 7.5, and you have the same thing with Norco. You have 5 325, 10 325, 7.5 325. So you can titrate that without a little bit. If you want to give somebody more narcotic without increasing their Tylenol dose, you can do that. So let's say you wanted to give, you don't want to double their Tylenol dose by having them take 2 5 325s. You just prescribe them the 10 325s instead, and then you accomplish your goal that way. Oxycodone, probably most famously, has a long-acting product called OxyContin, which is a Q12-hour abuse deterrent formulated pill, which has a lot of controversy around it. A lot of people blame this drug pretty much solely on blame the opioid crisis in the country pretty much solely on this drug. I think that's maybe a little bit unfair, but certainly it's a highly, highly abused drug. and it's one that is heavily regulated because it's so sought after on the secondary markets, or the black markets, I should say. You don't really get as much itching with morphine, but certainly you can get itching with this. It's expensive. It's inexpensive as an immediate release product. Now, the interesting thing was when the extended release product was out for quite a while, it was generic and pretty affordable. And you had a situation where the FDA all of a sudden said, you guys need to reformulate this. People are buying this in droves, crushing it, smoking it, snorting it, injecting it. Basically, they're getting legal heroin, or a drug that works just like heroin. It's pretty much the same potency. And they're getting it from a doctor and from a pharmaceutical company that knows that it's making, so you know what you're getting. It's kind of ridiculous when you think about it. But these patients were abusing this left and right. So the company was told to reformulate it. So they reformulated it as a crush-resistant tablet. And I'm told that if you try and dissolve it, it turns into kind of a gooey gel. I've never actually tried it personally, but it is very difficult to actually crush the tablet itself. So when you hear abuse deterrent in long-acting opioids, usually it's the tablet is very challenging to actually crush. But again, people will figure stuff out if they're put to the test. So back to acetaminophen quickly. This is one of those areas to be really careful with your Tylenol-containing products, as you're going to get patients that double up. They take Tylenol and they're also taking a Percocet, which we don't want. That's the last thing we want to happen with this, because they're likely going to overdose themselves on Tylenol. So just be careful. If you're prescribing Percocet or Vicodin or Norco, make sure you're upfront with the patient and tell them not to use any additional Tylenol-containing products. Hydromorphone is Dilaudid, and Dilaudid is probably one of the most effective opioids for acute pain management. It's a highly popular choice post-surgical. It's really popular in the ED for acute pain. It works quickly. It doesn't have it doesn't have extra metabolites. You can use it in renal failure patients. It's essentially a more effective morphine with a much more rapid onset and without the active metabolites. It's about 8 times more potent than morphine. So a couple things to consider. This does come as an oral medication and a IV. I don't think I have that on there. So it comes as a long-acting product, and it also comes as IV and PO immediate release. Okay. So with Dilaudid, one thing to think about, I'm going to show you some opioid conversion type stuff and talk about that in a little more detail here in a minute. But the PO form of Dilaudid and the IV form, not interchangeable one-to-one. In fact, no opioids really are. So be really careful. Like, I've seen providers say, oh, I was going to give them 2 milligrams oral of Dilaudid, but they can't tolerate that, so I'm going to order 2 milligrams IV. That's a massive dose increase. So be really careful. Like, half a milligram IV would probably be a more acceptable alternative. So you just need to be careful with how you're dosing some of these medications, and just keep your conversions in mind. And I'm going to have you actually do some problems. I'm going to put some conversion problems on the exam, which scares everybody, but honestly, I'll tell you exactly what you need to know. I'll give you practice problems that are almost identical to the test ones, and if you can understand them and do them correctly, you're going to be you're going to be in great shape. I don't know if I've ever had anyone actually get them wrong. Maybe like once in the several years I've been doing this, has somebody gotten, maybe a handful, let's say 5 people got a question wrong. It's really uncommon. So most people do great with them. It's a little bit intimidating though. The math's really easy, so I'll show you how we do it and I'll walk you through it. But just so that's coming up, you can keep that on your radar for now. This is more of an inpatient medication than outpatient, so you're going to see this used as, again, for a lot of scenarios. This is a really popular choice for PCA, or patient-controlled analgesia, which I've got on the next slide. Here we go. So PCAs are basically, you can see this kind of big syringe pump type thing here, and this guy's, or gal, I guess I can't tell, has a button. And PCAs can be set up with a lot of different scenarios. So you can have a PCA that's going continuously, so maybe there's a low basal rate going, and then that patient can press that button when they want more pain control. So you can set the PCA so that there's a lockout interval, so they can only press that button so many times in a specific time interval, so in a day or an hour, and that it maxes out. So if the person goes trigger happy with their pain control right away, Oh, that's all they get. And that's something that usually doesn't happen. Most of the time, this is pretty well controlled, but you get the point that it's very hard. You can't really overdose yourself on this because you can't just keep bumping yourself. Eventually, the machine will stop you from doing that. So there's a lot of interesting roles with PCA. It's a really popular choice. It's got great patient satisfaction associated with it because people like being able to have some control over their pain management. And it's just it's a very effective way to deliver opioids post-op. All right, fentanyl. Fentanyl is a pure synthetic opioid. It's extremely potent. So when we talk about potency of fentanyl, you're talking in micrograms usually. Fentanyl is dosed 50, 100 micrograms a dose, whereas like morphine, Dilaudid, they're all dosed in milligrams. So you're looking at a much, much more potent product. However, don't let that scare you away from it. It's very effective. It's not available orally, so it's the only one we've talked about so far that isn't. It's mostly used IV and transdermal. However, it comes as this thing called a lollipop / Actique. I think somebody photoshopped this. I found it on the internet, but it's kind of funny. I don't think kids actually ever would use this. So the product is highly lipophilic. It doesn't absorb well to the GI tract, but you can give it in this lollipop form and cheek it for a certain number of time, and you'll end up with a response that way from having the drug. It's got a very fast on and offset. And transdermally, it's got a 72-hour patch that's really popular for chronic pain, which we'll talk about here in a second. Oops. There we go. Fentanyl patches, or Duragesic are the brand names of these, can be applied in these locations, so chest, back, hip, arm. The fentanyl patches, just like most patches, contain a reservoir of medication, so you're putting a patch on, you're going to get a concentration gradient as the drug flows into your skin. You're going to get kind of like a depot effect locally where that patch is applied, and then over time that'll leach into your body. So usually every 72 hours is really common dosing, and you can dose them variably. So they come anywhere from 12.5 milligrams per hour release, micrograms, per hour release, up until like 100, or maybe there's even higher ones than that. So you can really titrate there. You can wear more than one fentanyl patch at a time. So if you're in between doses or need some extra, you can do that as well. These are really dangerous for people to get a hold of and eat. So like if a kid chews on one, like I don't know what kid would maybe put this in their mouth, but maybe like a really little baby gets a hold of one and puts it in their mouth. I could see my daughter doing something like that. Older kids, probably not as big of a deal. It's not like it's flavored or anything, or it looks like candy. It's usually just a clear patch. But pets too, if they get this, that could be a very quickly fatal experience. If you think about fentanyl, so if you have a 75 microgram per hour patch and you have 72 hours worth of medication in there, that's a lot of fentanyl. And so if a kid gets a hold of that and starts chewing it, it's going to absorb buccally and it's going to be very toxic, and they could easily die from that. So very important to dispose of these properly and not to leave them laying around. That's all I'll say about that. Opioid onset. So here's bolus IV injections. Let's see. So here's morphine. Morphine's kind of the slow one, kind of has a slow onset. Hydromorphone, pretty fast. Fentanyl, faster. We haven't talked about meperidine or methadone yet, but those have less of a role in acute pain. Those are there too. Alfentanyl and remifentanil are popular for procedural sedation. For certain cases, they're like super fentanyls that have a bunch of different associations with how they're, or a bunch of different specific indications for how they're used. They aren't really used for acute pain, more so again for procedural sedation. So these other fentanyls, I'm not going to spend a ton of time on. Again, most of these are going to be associated with procedural sedation. So it's going to fall more under anesthesiology's or an anesthesiologist or CRNA's realm of expertise. So again, not going to spend a ton of time on it, but they're here for your reference in case you ever hear them brought up. But for acute pain and general pain relief, these medications are not used, unless maybe really rare instances, but we don't use them at our hospital for that. There are super fentanyls out there. The only reason I put these on there is every once in a while you hear about something like this being used, or You'll hear about drugs cut with this. So carfentanil might be something you've heard of. It's a drug that was recently introduced as a adulterant, I should say, to local heroin supplies. And the problem is it's so potent that even if you adulterate a tiny bit with it, it's very hard to control the amount you're giving somebody. So it's super easy to overdose on it because it's such a high potency opioid. So we'll see bursts of this where we get just a ton of heroin overdoses, and it's because there's some new batch and somebody put something in it that they got a hold of, and it was some fentanyl. How people are getting a hold of these super fentanyls to adulterate heroin with, I have no idea, but it does seem to happen from time to time. Meperidine, not going to spend a lot of time on this. It's got no role in pain management. We only use it for rigors, and it's for low dose. So for post-operative shivering, post-anesthesia, post-paralysis, a lot of times they might give a small dose of meperidine, and I'm talking really small doses, like 25 milligrams, which doesn't mean much to you guys, but for pain management, you'd use quite a bit more. We don't use it for pain anymore because it's got a toxic metabolite and it's renally eliminated. It's got a lot of issues with it anyway. You should never see meperidine for pain. We just have much better alternatives now, and there's no reason to use it for pain management. Methadone is kind of a unique opioid. It's got the longest half-life of any non-extended release product at about 24 hours. Its analgesic duration is short at first, but with increased usage, it tends to pick up duration more so. So like if somebody's using it for acute pain, you might see it dosed like every 8 hours right away, although somebody using it chronically could probably get away with taking it once daily. Excuse me. Generally speaking, methadone hasn't been thought of as a good acute pain management medication, but actually there's some evidence that shows it does work pretty well, and it's relatively cheap. The problem is we actually can't get IV methadone right now. It's just went on shortage, so it might not be the most reliable supply. And methadone has a big stigma associated with its prescribing and use, and that's the reason. That's the reason is because methadone is used for opioid dependence. So there's methadone clinics that exist solely for the purpose of providing methadone to people who have previous opioid abuse. So once somebody gets off abusing an opioid, so let's say it's heroin or oxycodone or whatever they were addicted to at some point, methadone's a long-term drug that a lot of people will take. One of the reasons is because this is a drug that has opioid activity, but it also doesn't seem to have the staple euphoria associated with it. Even though it is a mu agonist, it doesn't seem to produce as much of a high, although there likely is some high, especially if you take enough of it. But the other thing it does is it helps prevent withdrawal symptoms from occurring because it's such a long-lasting opioid. So this is a really common drug to see people for dependence issues. The dosing is going to be the biggest difference. If you ever see methadone on somebody's medication list and they're taking it once daily at a really high dose, that's definitely a opioid dependence dose. If they're taking it like, and then by high dose, I'm talking about 50, 100, over 100 milligrams sometimes a day. If you're talking about acute pain, you might see somebody doing 5 to 10 milligrams, every 8 hours. So it's a totally different dosing strategy when you're talking about opioid dependence. We'll talk a little bit about more about methadone during drugs of abuse, bring it up, but I want to bring it up here because it is a pain relief option, certainly, and it is a cheap extended release opioid. Or excuse me, cheap. So it's not an extended release, but it's a cheap, long-lasting opioid, whereas like oxycodone extended release, morphine extended release tend to be a little bit more pricey. Here's a conversion comparison. So here's how you can see what converts to what. There's this opioid calculator if you want to go play with it. This one I actually like using. The website seems a little bit generic, but I did cross-reference some of their math, and I think it's pretty legitimate. Again, you will have to do some opioid conversions on the exam. I won't give you a chart like this, but for the specific question, I will give you the exact conversion you need to know. So if I'm asking you to convert from IV morphine to PO oxycodone, I'll tell you what conversion, and I won't give you a range. I'll say, 10 of morphine is 20 of oxycodone. I'll make it specific. But this is generally what we're looking at as far as conversion goes. The thing about this is that some things are not absolute. So obviously there's wiggle room in everything. So it's not a direct, 1 to 3 or 1 to 2 comparison. It's somewhere in between probably. And it's going to depend on the patient. We'll talk about this more in a couple slides. I want to show you fentanyl here, for example. this is a how we convert with fentanyl patches to patients. So fentanyl dosing is quite a bit different. And the way you would do it is you'd convert somebody all to oral morphine, and then you'd convert them to transdermal fentanyl based on what range they fall into. So for example, let's say somebody's doing hydromorphone IV in the hospital, and they're using a total of 10 milligrams per day. Well, 10 milligrams of hydromorphone IV, what's the conversion rate? Well, it's 1.5 to 30 milligrams of morphine. So you can do some quick math and figure out that, or figure out your morphine PO equivalents. Then you're going to go to your chart here. And that calculation comes, depending on what you use for that range, would come to be about 200 milligrams of PO morphine. So that puts you at 50, maybe, for your starting dose of your patch. Again, I'll go through some calculus, some review on this specifically during the next set of slides, or I either have it on the next set of slides or I have a specific document for it. But anyway, I'll go through all the math and how to do that specifically, and we'll go through that on class together too, so I can answer any questions about the calculations. But I'll get that stuff posted pretty quickly here. Anyway, back to the drugs. Tapentadol, not a super common medication. It's immediate extended release opioid. It's got mu agonist properties, plus it inhibits norepinephrine reuptake, which also I think I skipped over that on methadone. Methadone does that as well. It has some serotonin norepinephrine reuptake inhibition. Norepinephrine serotonin reuptake drugs are commonly used in mental health for things like depression, anxiety, and ADHD. But they also seem to have some benefit in neuropathic pain too. So maybe it's, kind of like a double mechanism there that helps with both the perception of pain from the opioid and also the inhibition of norepinephrine reuptake can help with some of the neuropathic pain as well. But it is marketed as a more tolerable option. It's supposed to have less GI side effects, but I don't know. It doesn't really get used all that much. It's quite expensive. Buprenorphine is a mu partial agonist. It's sort of a weak opioid. We don't really use this for pain. However, you certainly could. The problem with it is it's just not all that effective for pain. What we do use it for is the alternative to methadone for opioid dependence, and it's combined with a medication called naloxone, which we'll get to in a second here, as a drug called Suboxone. So what this drug does is it's similar to methadone in the sense that it's going to make people less likely to go into withdrawal if they're taking it. And also buprenorphine will compete directly with other opioids. So if you're taking buprenorphine and you inject heroin, it will compete directly for the receptors, and it's a partial agonist, so it's only going to elicit a certain amount of response before it kind of reaches its max approach or max response. And when that occurs, you don't get any more effects from the mu agonism, and in that case, you don't really get much euphoria out of it. So it can work for pain, but again, mostly we're going to see buprenorphine combined with naloxone. Naloxone is an opioid antagonist, which we'll get to in a few minutes here, but they put it in here because any type of opioid somebody will try and abuse. So if you combine the drug with essentially the antagonist of it and you try and inject that, you shouldn't really get an effect from it because you're injecting an opioid agonist and an antagonist at the same time. Theoretically, it would deter you from trying to abuse the medication. Opioid-induced hyperalgesia is a syndrome that's caused from increased pain sensitivity following exposure to opioids. So usually this happens if people are on really high doses. It's pretty well documented in animals. The evidence in humans isn't quite as good, but still prevalent. You can treat it with NMDA receptor antagonists, which we haven't really talked about yet. We're going to talk about ketamine in a little bit in a couple more lectures. I believe it's either during neuro or psych. We'll spend a little bit more time on ketamine. But ketamine's quickly, I'll talk about it really briefly right now, because ketamine is really becoming more popular as an alternative pain medication. Every once in a while you get somebody in the hospital, they just don't respond to opioids. Like I've had chronic cancer patients who are on huge doses at home, and ketamine works totally differently. NMDA receptors are, again, not to get into the mechanism too much right now, but what ketamine essentially does is it causes a dissociative type of effect. It's a sedative on its own, but at high levels it causes some dissociative types of of effects, and it can help with decreasing the body's ability to transfer pain signals from the central nervous system out to the peripheral nervous system and back, and that can help with the way the body perceives pain. So it's similar to how opioids do it. Opioids just are tricking your body into thinking that there isn't actually pain signals coming through, even though there are. But this is a little bit different, but it's essentially kind of doing the same thing, where it's working in the central nervous system to modify how your body's perceiving the pain signals your body's trying to send into the brain. So different, but ketamine is a good alternative for these people who have either opioid-induced hyperalgesia, where they're getting extreme pain sensitivity, or just really resistant to opioids in general. Naloxone, or Narcan is what you've probably heard it called, is a pure opioid antagonist. It competes and replaces opioids at the site of action. It's available in every form except oral. Its onset is in minutes. It lasts about 30 to 120 minutes. Now here's the bad news about it. It can precipitate withdrawal. So if somebody is high on heroin and you slam them with Narcan, they might be very upset with you for doing that. Now, if they're almost dying because they're in respiratory depression, it doesn't really matter what they think about you, right? Because you're saving their life. But at the same time, we do try and be a little bit careful, because if you do that, you can end up with somebody who's really agitated. They could threaten your staff or yourself. You want to be careful how much Narcan you give somebody at once. Narcan, besides reversing overdoses, is also used commonly post-operatively or procedurally. If somebody gets a little bit too much narcotic, they might give a little Narcan to reverse it. And again, life-threatening overdoses. A lot of stuff on the news about Narcan recently. Pharmacists in some states can dispense this. I'm not sure where Minnesota's at with that. But a lot of people are getting take-home kits with Narcan in them. We have some that we put together for our emergency department patients. And the idea is that if you have somebody with you in the community, or maybe you're a parent and you have a child that's has a history of heroin abuse, or a loved one, or a friend, or maybe you're a heroin addict yourself and you hang out with a lot of other heroin addicts, and you happen to have a kid on you and your friend overdoses, you can administer it on the spot as opposed to waiting for emergency medical services to get there. And so the idea is that we probably aren't going to solve the world's heroin problems in very easily, or within the next few years even, but at least we can make it less burdensome on everybody and hopefully save some more lives in the process by giving these people the antidote, because the antidote's highly effective. Assuming they aren't mixing the heroin with anything, it works quite well. So in the case of administering it in the field, it can be advantageous for somebody to have this immediately accessible. Sooner you have access to it, the easier it is to bring somebody back. Somebody goes into respiratory arrest, eventually their heart will stop, and then you can't bring somebody back. No amount of Narcan can restart a heart once it's stopped beating for a while. So it's really important that this be done quickly. Again, highly effective, but certainly has its limits as far as what we're using it for. If somebody is opioid naive, it shouldn't have any effects whatsoever. It should basically be like if you injected somebody with saline. So it can be used as a diagnostic tool too. If somebody shows up or has some symptoms and they're just seeming weird, you might think opioids, maybe, I don't know, you aren't sure. Give them a little bit of Narcan and see if they respond, and if they do, it's probably an opioid. Naltrexone is another pure antagonist, but it's a different use. It's not an emergent drug. It's used as a couple different items. So there's a PO medication that has about a 72-hour duration, and an IM drug every 4 weeks. So, excuse me, I'm yawning. So for opioid dependence, this is a medication that's used as a long-acting deterrent. So the idea is if you can convince somebody to take the oral drug once daily, and they decide they want to relapse and shoot up heroin, they aren't going to have any effect from it because they have an antagonist aboard. If you don't rely on your patient to take an oral medication every day to deter their abuse habit, IM drugs, the IM drug is going to be a more beneficial option. You give it to them, and then for 4 weeks, if they try and inject something or use opioids, they aren't going to get much of an effect from it. They actually use this for alcohol dependence too, which we haven't talked about. Alcohol doesn't work like an opioid, but it's thought there might be some crossover effects into the endorphin system and the mu receptors triggered by natural endorphins during alcohol consumption. So possibly there's some effects, and there's actually some pretty good data that supports that naltrexone is effective in those patients too. And this should be another drug that's pretty benign if you're opioid naive. The major danger would be the same thing with naloxone. If you precipitate withdrawal in a patient, that can be problematic, at least fairly uncomfortable for the person withdrawing from opioids. Some other quick things. Nalbuphine is another drug we kind of treat as an antagonist, even though it's a partial agonist. It also has some kappa agonist things. The only thing we use it for really is opioid-induced itching. It's really common in OB. They like to use it up there a lot for like post-epidural itching, but that's about it. And we usually use fentanyl for our epidural, so there's not a lot of that going on anyway. It's not a super common drug. Methyl naltrexone is a peripherally acting mu antagonist, which is a really interesting treatment that's come out recently. So this is a drug used specifically for opioid-induced constipation. The reason why it's cool is because it doesn't cross into the central nervous system. So if your patient, like let's use a chronic cancer patient who's got a lot of pain, who's on high doses of opioids, we don't want to limit their ability to get analgesic relief from their opioid regimen. So we don't want to reverse them. But this drug will reverse the effects of opioids in other parts of the body. So, for example, the GI tract, without getting across the blood-brain barrier and into the brain, where it could reverse the actual analgesic effects of the opioid. So, it's a pretty quick-acting drug. Usually, there's some protocols around using this. You have to have tried other bowel meds first, and you have to have gone a certain amount of time without having a bowel movement. But it does work quickly. It actually isn't too expensive either. It's about $70 for a dose, and for people with intense, constipation due to high amounts of opioid use, this is a medication that can come in handy quite often. Cough suppressants. Opioids are also cough suppressants. So codeine is technically an analgesic too, but probably more often used as a cough suppressant. Codeine is, I put it under cough suppressants and not under the main pain management drugs, because I just don't think codeine is all that effective for most people's pain needs. I think when people prescribe it, they prescribe it with acetaminophen, and that's called Tylenol 3 or T3, which is Tylenol. It's 300 milligrams of acetaminophen and 30 milligrams of codeine. And I think what people are getting is maybe a very mild opioid effect off of it, but also I think providers can justify to patients, well, I'll give you some codeine, and that might be enough for them to. It's sort of like bartering, right? You don't want to prescribe this person oxycodone because you don't think they really need it. So codeine's okay. The person might be very opposed. They're like, oh, ibuprofen doesn't work for me. I got to have something stronger, quote unquote. Well, this is a drug that you could maybe slot into there, even though it's not all that strong. Although it seems like a lot of people are abusing codeine. I've heard that codeine's a really hot street drug right now. Honestly, I'm not sure why. I think you'd have to take a ton of it. It's about a 1-to-10 ratio to morphine. So codeine gets metabolized into morphine, albeit slowly. So you are going to get those opioid effects. It's just going to be like you have to take quite a bit more codeine to actually get to the potency that you would want. Dextromethorphan is something you'll see in pretty much every over-the-counter cough suppressant. It's not an opioid, really, but the structure is designed to mimic codeine. Because opioids are cough suppressants, dextromethorphan was designed that way specifically. Now, I'll put the caveat in here, and I put the bullet point at the very bottom here. Cough suppressants in general, scientifically, have not been proven to be really effective at all. There's actually no cough suppressant on the market that's proven to really work better than placebo in an actually well-designed study. So whenever you prescribe somebody a cough suppressant, know that you probably aren't going to do all that much with what you give them. It drives me crazy. I tell my wife this all the time, and she's always like, when one of our kids gets a cold, oh, what can I give him? Nothing. Water. That's it. So, I mean, it might make some people feel better, but ultimately there's really no evidence behind cough suppressants. So even though dextromethorphan and codeine are marketed as cough suppressants and opioids do have a cough suppressing reflex, you probably aren't going to get a whole lot of benefit from these drugs. At least I wouldn't expect it. So we talked about opium being used as an antidiarrheal medication. We've talked about the bowel effects of opioids. Lomotil is a drug that was made specifically to be antidiarrheal, so it's called diphenoxylate and atropine. Diphenoxylate doesn't really absorb systemically. However, the drug is still controlled. The idea is that somebody could get it and maybe try and inject it into their bloodstream and maybe get high off of it. I don't know. I think that's a stretch. So they formulated it with atropine so that If you did do that, you'd get some really bad anticholinergic effects, and theoretically, you'd be less likely to do it again in the future. Kind of an interesting deterrent method by convincing or by threatening people with anticholinergic side effects. Because honestly, what drug abuser is going to look at this drug and be like, oh no, that's got atropine in it, I'm not going to inject that? I mean, people don't. I don't think people think like that. Maybe they do. I don't know. But I think it's funny anyway. Lamotrigine is not a super common medication. It is a fairly potent antidiarrheal option you could give somebody. Loperamide is the more common one. That's Imodium, not absorbed systemically. It's oral only. It's an OTC drug that's fairly common. It's a relatively effective antidiarrheal medication. Okay, so we've talked a lot about pain and a lot about acute pain. Acute pain is kind of like, well, I think it's pretty straightforward. You usually want to use the smallest dose you can get away with, and you get the patient off the medication as soon as possible. So prescribing small amounts, giving as small amount as you can get away with. So, some patients might need a little bit more than you might expect. So, if somebody's larger or younger, they might require higher doses. But for the most part, I would stick to 1 or 2 tablets of oxycodone or Percocet or hydrocodone or Norco, and that should be fairly effective for most people's acute pain. When it comes to chronic pain, this gets tricky because you end up with people who are on a lot of opioid, and you might get into situations where you don't really know exactly what to do, or one of their opioids aren't working anymore, and you're like, should I increase the dose? Should I try something differently? It can be difficult to say. So without really going into the clinical strategy, because I'm not a chronic pain specialist and I really do think it varies, what I'll give you the tools for is how to convert somebody off of something like this. So what you want to do is assess what they're using on a daily basis. So that's the first step. And if they're using a lot of short-acting medication, consider a long-acting agent. So that could be applied to, let's say maybe somebody is post-op and their post-op healing process just isn't going well. They're in a lot of pain and they've been going through your Percocet prescriptions like candy. Well, maybe you should consider, are they diverting it or something like that? Should always be your first question. Do they actually need the medication? Are they really in a lot of pain? Always be on your radar. It's always good to be suspicious when it comes to opioids. I'll talk more about that in a second here. But the other thing to think about is, is it time for a long-acting agent? And if they're going through a lot of short-acting medication, and the surgical outcome that you desired hasn't happened, and they're going to need to have some more advanced pain control before you can just figure out a new surgical strategy for the patient, that'd be an instance where let's add something long-acting here. But to do this appropriately, first you want to convert everything usually to morphine equivalents. Morphine equivalents are kind of the easiest to work with. You can convert direct to something else, but a lot of sites will recommend going straight to morphine. So let's go back to our little conversion thing here. So you convert everything to your morphine equivalents and then convert over. Or, if you're going from, let's say they're in the hospital and they're on Dilaudid IV and you're going to oxycodone PO. That's kind of the example I gave earlier, but it's an example of how you could convert somebody that way. So you can go direct as well, but a lot of guides will tell you to convert to morphine first and then convert the morphine equivalents to something else. But there's really no reason why you actually have to do that. It's just a recommendation, I think, to streamline things generally for people. But after that, you want to select your long-acting agents. So our long-acting options are kind of limited. And you have fentanyl patches, morphine extended release, and oxycodone extended release. Yes, I mentioned a couple other ones. There's that hydrocodone product. Those are expensive, and people don't really use them as much. These are the common 3. And anytime you give somebody long-acting, you still need to prescribe them something immediate release for breakthrough pain. That's a requirement. And then the other thing that confuses people a lot is something called cross-tolerance. So every time you switch somebody from one opioid to the other, so let's say we're going from oxycodone to fentanyl, it doesn't matter what you pick, all of them are the same, you're going to decrease the dose equivalent total by about 25 to 50%. So that's a big confusion aspect when it comes to calculating this. It's not just converting over and doing the math. You have to decrease that final dose by 25 to 50% in order to be able to to make up for cross tolerance, because that person is going to theoretically get some added benefit of analgesia just by having a new drug on board. And they aren't going to need quite as much to get them to the same level they were before. Withdrawal symptoms, I've mentioned this a couple times. It usually occurs about 3 weeks of daily use. So on short-term acute management, you don't have any risk of withdrawal. Opioid withdrawal is not fatal. I said rarely fatal down here. The only way opioid withdrawal would really be fatal is if your patient was really frail to begin with. Maybe if you're talking about like a really malnourished cancer patient that ran out of their opioids and went into bad withdrawal, yeah, they could actually die from that. But the general person, like if you talk about a young heroin addict, if they go into withdrawal, yeah, it's going to be very unpleasant for them, but they probably won't die. The odds of them dying are very slim from opioid withdrawal. Typical symptoms: 3 to 4 hours after the last dose, craving, anxiety, getting fear of going into withdrawal if they've had withdrawal symptoms before. 8 to 14 hours, restlessness, insomnia, yawning. Some symptoms that are kind of like cholinergic effects, so runny nose, tearing, sweating, and some GI effects. 1 to 3 days after that, usually you have intense GI effects, so maybe muscle spasms and tremors, maybe some cardiac effects. But after 3 days, it's sort of like you're in the clear. At that time, the question is the person going to go use again, or is it cold turkey quitting? Doesn't seem to work all that well with opioids, which is a whole other topic in and of itself. But anyway, that's sort of the timeline you're going to get. Again, rarely fatal. Methadone and buprenorphine used to prevent these symptoms from occurring. Some other drugs like clonidine, benzodiazepines, antiemetic medications, which we haven't talked about too, can help mitigate symptoms as well. We talked about some side effect management already with itching and nalbuphine. But for more conventional itching, you have antihistamines. Diphenhydramine is used sometimes, but it's pretty sedating. We like to use hydroxyzine commonly for opioid-induced itching. That's a pretty popular one. It's less sedating than Benadryl. Constipation, again, bowel regimens are required. We'll talk about bowel meds in a lot more detail coming up in the GI series. But standard bowel meds that you could get, most of these are over the counter: Senna, Docusate, polyethylene glycol like Miralax are all appropriate. And of course, methyl naltrexone we already mentioned. And addiction. So addiction is of course a major issue. If the estimated risk for getting addicted to an opioid is about 3 to 5% of any patient who takes the drug. So if we think about how common and popular these drugs are, that's a lot of people that are potentially at risk. And it's not to say 3 to 5% of people will get addicted, but that's about the amount of population it's likely to have that addictive behavior or personality or response to the opioid that makes them feel euphoric. I've personally taken hydrocodone before occasionally for medical reasons, not recreational, make that caveat clear. And I don't find it to be euphoric at all. I get sleepy off of it, and I actually find that it helps with pain. So it actually seems to do its job quite well for me. But I'm certainly not one of the 3 to 5%. But for those people that are, who get that euphoria, that's where we have to be really careful. So it's important, I think, when you prescribe an opioid to make a patient aware of the risk, to talk to them about addictive behavior. And I know it gets tricky because if you're doing post-op, if you're if you go into surgery or work with a surgical practice and you're doing post-op pain management, it can be tricky when you're dealing with all these patients who are post-op, might not be with it. You're writing scripts for this. You have kind of a standard script you give everyone, a Percocet or whatever. And just making sure that you're taking the time to talk to that patient and explain to them, this medication might have some addictive properties to it. And they might say, hold on, my family has problems with substance abuse. My father was an alcoholic. I don't touch anything like that. I don't want anything like that. I don't know what it is, or maybe they aren't familiar with the drug. So I think it's really important to make people aware so they don't accidentally take something that could end up harming them in the long run. Sure, the pain is a big deal, but I've talked to so many patients who tell me that, I got prescribed that Percocet after a surgery. I didn't even touch it. I don't touch that kind of stuff. So that's another thing to think about too. If your patient's not going to take the medication, don't prescribe it to them, because all you're doing is you're adding pills out into the community, and maybe they have a son or a grandson or somebody who's going to divert that medication and sell it or abuse it. That's really how a lot of this stuff gets out there, because these prescriptions are so prevalent. And so I think, I'm not saying not to prescribe the medications, but we as healthcare providers have to really take this on ourselves, and be careful about how we're prescribing it. Don't prescribe anything your patient doesn't need, and make sure you're keeping your doses small. Like one example I'll have, not doses, but your quantities small. One example I'll give is when I was in my in-laws cabin in Wisconsin, and I was going way too fast on a jet ski several years ago, and I hit a big wave. I flew off. I landed really weird and kind of hit my ribs funny. I don't think I broke my ribs. They told me I didn't break them, but I think I actually did. Anyway, it was really painful. The doctor prescribed me Norco, and she didn't ask me how many I needed or how many I might need or how often she thought I needed to take it, or even really if I've ever taken it before. She just said, well, I'm going to give you something for the pain. I said, okay, sounds good. I mean, I was a pharmacist at the time, so I'm like, I can handle whatever. I don't really need to ask these questions. But it kind of was surprising that she didn't engage me more in the discussion. And then I go down to the pharmacy at this rural hospital in Wisconsin, and they give me 60, which is a lot. I don't think any doc in my ER would ever prescribe anyone 60 who just walked in with an injury. Now, granted, maybe she's like, he seems like a legitimate guy, he's not an abuser, but I still have probably 50 tablets of that. Why do I keep it? I don't know. Maybe I'm going to get hurt someday and be in a lot of pain and want to take something before EMS can get to me if I like break my leg or something. You never know. But I'm exactly one of those. I'm one of those examples of people that I'm complaining about, right? Why am I hoarding medications? I don't know. I should just get rid of it. But again, it's kind of nice to have it around if you really need it. If some accident happens and you need some pain relief, or if you just have that really bad headache that won't go away that maybe you get once a year. Not saying that's me, but I'm just saying I've talked to people who keep this stuff around just for those reasons. And yeah, it might be nice to have something a little more strong than your average OTC medication. So anyway, the whole point of this is that people will hang on to the drugs you prescribe them. So A, be careful what you prescribe, and B, watch your quantities. Don't give somebody 60 tablets who came in from urgent care. Okay, if they need more pain control, they can follow up with some other doctor. That's all I'll say about that. These last two bullet points. Minnesota Prescription Monitoring Program. If you haven't heard of this, it's super important. I think somebody comes in and talks to you about it at some point, I hope anyway. But if not, you're hearing about it from me. You can go to this website. This is all run through the Board of Pharmacy, and it allows you to check patient history. So all pharmacies are required by law to report controlled substance dispenses to the Minnesota Prescription Monitoring Program, and providers and pharmacies are required to display their information too. So if I go in and look at one of your patients, I could see if you've prescribed them narcotics. So like, let's say somebody comes into our emergency department. This happens a lot. One of my providers comes to me. Usually they run it on their own, but every once in a while they ask me to do it, whatever. So they come and say, hey, Chad, can you run this for me and look at it and tell me what you think? Or they might have ran it and asked me if I could double check it and see what I think about it. And it's pretty easy, actually. You can see if somebody is going to lots of different providers and lots of different pharmacies, or you can see if somebody's getting it consistent. It's like, yeah, that person gets 30 Percocet from the same provider, fills at the same pharmacy every single month. It's like clockwork. So they're getting something regular. I mean, maybe that's not the most appropriate practice, but it doesn't look like they're drug shopping. So that's one of the things you can use the PMP for. And I really want to stress that we don't want to, dehumanize our patients by making them all out to be these, drug hungry addicts. But you also have to protect yourself as a healthcare provider. And I think it's really important to make sure that you take opioid prescribing seriously, and when you are prescribing, that if you do have any sort of hesitation, even if you don't, maybe check your PMP. If it's a new patient who's just seeing you, check the PMP, because people can be good actors, and the last thing you want to do is get involved in some kind of a case because you didn't do your due diligence and prescribe somebody opioids inadvertently, who didn't actually need them, who was diverting. And providers and pharmacists have gotten prosecuted, and I don't think this happened in Minnesota. It has happened in other states where providers and pharmacists have gotten prosecuted for not doing their due diligence and diverting. Now, some of those cases were really bad, like pharmacies dispensing absurd amounts of narcotics and not cross-referencing what they were doing. But my point is that this is watched by the DEA, and there is inherent risk to prescribing opioids. So do your homework, cover your bases, make sure you check this, on your patient, especially if they're new to you, or especially if you have any red flags going up during an interview or a physical exam. Carrying over to heroin use, I think some people think this is a myth, but it actually is well documented and studied that oral medications and abusing like oxycodone and hydrocodone regularly, people can't get enough of it, so they end up going to heroin. Thing about heroin, it's cheap, it's plentiful, and we have supplies coming up right from the source. So I'll talk more about that during drugs of abuse, but heroin's really easy to get in Minneapolis. And drugs that are produced by pharmaceutical companies are less easy to get on the street, are more expensive. Because of a lot of the crackdowns that's happened in recent years, that's just driven more and more people to use heroin because it's cheap and they get a better high from it. So it certainly is true that it does carry over to heroin use. All right, just a couple more slides. I know this is a long set of lecture here, but bear with me. Tramadol is kind of an opioid. It has some weak mu activity and actually was moved to a controlled substance recently, I think last year or the year before they did it, and it is a control 5 now, I think. So it's not really a high control status, but what that does is it allows the DEA to police it a little bit more. And people were definitely abusing tramadol. I mean, no questions asked. So tramadol, the fact that it wasn't a controlled substance for such a long time was kind of ridiculous. So finally it is now, but does that deter abuse? I don't know. It does pull up on the prescription monitoring program now, so we are able to see that now that it's a controlled substance, so that does help you see if somebody's filling tramadol. Tramadol also inhibits serotonin norepinephrine, so similar to methadone. It is oral only. It comes as a regular and an extended release product. It's usually dosed about every 8 hours. Usually a acute as needed medication. Sometimes you run into people taking these on a regular basis, which there's a whole ethical and problematic discussion there, but it probably goes for any short-acting pain medication. Shouldn't really be used on a regular basis, but it happens certainly. This is a drug that you could use in conjunction with pretty much everything except opioids. So you aren't going to use tramadol with other opioids, but sometimes providers will like to use tramadol plus maybe an NSAID in the event that they don't want to start like oxycodone or hydrocodone on a patient. It is renally eliminated, so if patients have renal disease with creatinine clearance less than 30, you wouldn't prescribe it. Lidocaine patches, something that I think people should keep in the back of their head. I put this one in my miscellaneous pain medication bucket, kind of like diclofenac gel. Lidoderm patches are an interesting delivery system. So the patches are pretty big, so you can see it covering this person's back. It's a pretty decent sized patch. I'm trying to do a visual here, but of course you guys can't see me, so that doesn't matter. But the nice thing about lidocaine patches, you can actually cut them. So you see the smaller strip here. And they actually got their start for post-herpetic neuralgia, which is an extremely painful syndrome. And it's local for the most part. So you can, there is some systemic effects, but a lot of them are local too. So you can actually cut the patches to fit where the neuralgia is most focused and cover somebody's area that way. Lidocaine patches also have some other great advantages for like low back pain. You can use them for osteoarthritis, maybe try them for knee pain, joint pain. Certainly worth a shot. Very minimal side effects. The one thing to remember about them when you prescribe them is you leave them on for 12 hours and then take them off for 12 hours. The reason is that as lidocaine absorbs, we talked about lidocaine very, very briefly during cardiology. It is an antiarrhythmic drug, and it can cause cardiovascular related effects. So I want to make sure we're taking that patch off for at least 12 hours and putting back on. The odds, if you left it on, would you get, like excess absorption? Probably not, but it's just a precaution. And you can wear up to 3 lidocaine patches at a time for that 12-hour window. So if you imagine how big these things are, and you could cut them to fit, you could like take up almost half of a normal person's back with these. Maybe not half, maybe like a third, but a decent chunk of skin could be covered with these things. So again, a nice option for some of the more tricky neuropathic pain indications out there. And we'll talk about neuropathic pain a little bit more during the neuro series as well, because it's a little bit of a different ball game. We use kind of a totally different set of drugs for that. But this is one that crosses over into both. I think there's some interesting applications to lidocaine patches, and certainly they're worth a shot. When you have patients who have all pain and they've tried all types of different medications without much success, what's this going to do that's going to be harmful to them? It can only really benefit them. They're going to try it. They're going to get effect from it pretty much within an hour or two after putting it on. And if they don't, it was a trial worth a shot, and you can move on to the next option. But it certainly is an option to keep in the back of your head. Oh, I did put neuropathic pain on here. I think I talk about this a little bit more during the neuro lecture too, but I'll go through it really quickly. Multiple sources with neuropathic pain: diabetic neuropathy, post-herpetic neuralgia, spinal cord injury, MS would be kind of the common ones you'd see. So we're really talking about non-traditional agents here. So opioids are not first line, and the sensation for nociceptive pain versus neuropathic pain is different. So you got pins and needles, burning, tingling type sensations. Your first line treatment are drugs we haven't covered yet. So there's anti-epileptic drugs that are on the market that are primarily actually used for neuropathic pain and not really used for epilepsy anymore. And we'll cover those during neuro, more detail. And antidepressants. So we talked about serotonin, norepinephrine reuptake inhibitors. You may have seen ads for Cymbalta. Cymbalta has gone generic within the last couple of years, so I don't know if they advertise it all that much anymore. But it used to be advertised as like the antidepressant that also targets physical pain. And anyway, it's been shown to be actually pretty effective for neuropathic pain. Same with some of our older antidepressants like tricyclics. And again, we'll cover these in detail in psych, so don't worry about them too much. I just wanted to bring this up quickly here. So that's pain drugs for the most part. We'll talk about how we manage osteoarthritis and rheumatoid arthritis in the next series of lectures. So I will not see you guys next week, but I will see you guys. Let's get my little date box up here because I can't even remember. I'll see you guys on the 22nd. We'll do osteo and rheumatoid arthritis, and then we'll also we can use some time for review as well. I will post some problems that go through the calculations for the opioid conversions for you guys to work on some of that, so you can get a head start on that if you want to. So, anyway, there'll also be some forum online, so if you have questions about pain management, you can post stuff on there if you think it'll be helpful for your colleagues. Thanks.